Hi, my name is Rieveschl. I'm an ophthalmology first year, and this is my grand rounds presentation. It's titled, Why is my pupil dilated? Special thanks to Dr. Hatcher for not only helping me see this patient, but helping me organize this presentation. Here are my CME slides. I have no disclosures to make today. So this was a patient that I saw at Our Lady of the Lake. She's a 19-year-old female presenting to the eye clinic. Yesterday evening, she had noticed that her right eye was dilated after changing out her contact lenses. She endorses mild blurriness in the right eye. She had used some artificial tears last night, but hasn't used any other eye drops or ointments or any other medications for her eyes. She denied any double vision, pain, redness, discharge, flashes, floaters, loss of vision in either eye. There was no history of trauma or chemical exposure. And past ocular history, other than wearing glasses and a monthly contact lens, it was pretty unremarkable. She said she cleaned her contact lenses every night. And the family history was only significant for a father with retinal detachment. So here's a photo of the patient. If one of my colleagues could tell us about that.
I can go. It looks like an external photo. Don't see any like gross abnormalities of the orbits or periorbital skin. Lids look symmetric. Don't see any lesions, but whenever you take a look at the eyes, her right pupil was significantly more dilated when compared to the left. And I guess there's not like a picture of the dark versus the light room, but it still looks like it reacts a little bit to direct light, but not significant constriction.
Good. Yeah, I like, and you'd notice too that there's no ptosis that you can really appreciate. And like you said, pretty poor light response. The pupillary margin appears pretty regular. You don't see any obvious irregularities. It's fairly round. But yeah, good job. Here's just a little closer up picture kind of the same thing. So her exam showed a visual acuity of 20/20 in both eyes. Pressure was within normal limits. As we saw in the prior image, her right pupil was very large, very minimally reactive. There was no APD by reverse, and there was minimal pupillary reaction to near vision on convergence. Otherwise, extraocular movements were full. There was no deficits appreciated there, and her visual fields were full. And for the rest of the exam, really kind of the only pertinent thing that we could see on the slit lamp exam was that right pupil was large. It was regular. There was no vermiform iris movements, no evidence of any kind of trauma, and really pretty unremarkable, as was her fundus exam in that eye. So this is a case of anisocoria, which is typically by definition greater than or equal to 0.4 millimeters difference in pupillary size. There's a potential wide range of causes ranging from anything that it could be benign to something that's very life-threatening. So it's important to do a workup for this to get to the bottom of it so you don't miss something important. But generally, you kind of break it down into impairment of either dilation, which would be a sympathetic response, or impaired constriction, which would be more of a parasympathetic response of the pupils. So what would you all include in your differential diagnosis for anisocoria?
Horner syndrome, Adhi, third nerve palsy.
Yep, those are all good ones. So I hinted at it too, that the parasympathetic and the sympathetic systems are at play here. And so those were some good ones. And I'd like to break it down into sort of what the abnormal pupil is. Is it constricted or is it dilated? So the differential for when the abnormal pupil is constricted would include something like a unilateral exposure to a miotic agent. It could include iritis, the inflammation of the iris, as well as potential synechia that are kind of mechanically obstructing the iris from dilating or constricting. Horner syndrome is another one. Argo-Robertson pupil, and then a long-standing AD pupil is also a possibility for that. And sometimes it can be hard to tell which pupil is actually the abnormal one. So Matt, I think you might have referenced to it, but you typically want to look at the patient in dim light or dark and compare it to how they look in bright light. So when the abnormal pupil is the one that's constricted, typically the anisocoria, or the difference between the pupil sizes, will be greater in the dark. And vice versa, when the abnormal pupil is the one that's dilated, the greater anisocoria will be the one that's in the light. Or the greater anisocoria will be in the light if the abnormal pupil is dilated. And so differential diagnosis for this would include iris sphincter muscle damage, typically from like trauma or even surgery. It would include AD pupil, cranial nerve 3 palsy, or potentially a pharmacologic mydriasis. And then I put physiologic anisocoria in here as well. It doesn't exactly fall into either one because actually it's not necessarily greater in the light or the dark. Typically it's fairly even in both. So here's the flow chart that I hope to explain to you all today, and hopefully we can, it will make sense by the end of the discussion. So we've kind of started from the top here. We've said that, we've looked at the pupils, seeing if they're reacting normally to light. And then we also want to assess whether anisocoria is greater in the dark or not. And that'll put us on one side of the spectrum or the other. So we'll come back to this later after we talk about a few more things. And you'll notice too that actually on the left side that typically the deficits are going to be more on the sympathetic side of the spectrum. Or that the abnormal pupil will be the constricted one. And then on the left side, the abnormal pupil is typically the one that's going to be dilated. So before we get too much into the details there, I'd like to do a little bit of an anatomy review and kind of talk about the mechanisms at play. So in this case, the sympathetic pathway is very important. It's controlling the pupillary dilator muscles. So to go through the pathway, typically we think of it as starting in the hypothalamus, and that's where the first order neuron begins and travels from there down through the hindbrain, through the through the spinal cord, and down all the way to the ciliospinal center of bridge down below. And that's where the first synapse is, where it will synapse with the second order neuron. And from there, usually around from C8 to T2 is where it exits via the ventral rami and will end up with the parasympathetic plexus and will begin to then travel back rostrally again. You'll notice how close that second order nerve comes to the apex of the lung. So apical lung disease, such as like a tumor, can often affect the pathway here. And then that second order neuron travels up and will then synapse again at the superior cervical ganglion, right around the bifurcation of the carotid, and then travel up with the internal carotid into the cavernous sinus briefly, and then it sends out some branches, one of which to the Mueller muscle, which is why you can end up with ptosis when this is affected, one of which the long ciliary nerve, which goes to the dilator muscles, and then you can also see another branch earlier on that's going out to the face where the sweat glands are. And of note that the dilator muscle is contracting in response to an alpha-1 adrenergic stimulation. And then for the parasympathetic pathway, this is going to the pupil sphincter muscles, causing constriction of the pupil. And kind of the most important area probably of control, I would consider the Edinger-Westphal nucleus. That area receives input from the two pretectal nuclei, both the ipsilateral and the contralateral one. And this is in the midbrain, just for your reference. And the pretectal nucleus gets its information from the optic nerve. So you'll see that the optic nerve, coming from one eye, you'll see the temporal optic nerve from the retina will come, and it doesn't decussate, but the nasal one does. And so those feed back to the pretectal nuclei, which then feed back to the Edinger-Westphal nucleus. And from there, you have a fiber that runs through cranial nerve 3 and will synapse in the ciliary ganglion. And then from there, that other nerve, the short ciliary nerve, will go to the sphincter muscle. And this is a muscarinic stimulation, which is acetylcholine. And this is really the pathway for reaction to light. So the first condition that I want to talk about that's on our differential is physiologic anisocoria. And I'm not going to talk too much in detail about these, but it's more to get a general understanding and to help us kind of work our way through that flow chart that I referenced earlier. So this is the most common cause of unequal pupil sizes. It affects actually up to 20% of the population, so pretty common. But it's typically benign, typically asymptomatic. And oftentimes the anisocoria is fairly minimal. It's not any greater than about 1 millimeter. And the light and ear responses are typically intact. And again, like I said before, it's fairly equal in the light and the dark. So the next one is Horner syndrome. In Horner syndrome, you have a lesion anywhere along the oculosympathetic pathway. So anywhere, whether it's the first order neuron to the third order neuron, could be the one that's affected. And this results in unopposed parasympathetic drive to the pupil that results in ipsilateral meiosis. So you end up with ptosis because the mular muscle is affected. You end up with anhidrosis because we show those nerves going off to the sweat glands. And then you can also, and then you have the anisocoria that's more evident in the dark. So the first test for Horner syndrome that I'll talk about is the cocaine test. So the mechanism of cocaine is that it blocks the reuptake of norepinephrine at the postsynaptic third order neuron. So by that, in a normal eye, it will cause pupil dilation and eyelid retraction. But in Horner syndrome, since the pathway is obstructed, then you don't get normal norepinephrine release. So it doesn't so much matter that the uptake is blocked because you're not getting release in the first place. So cocaine ends up having no effect, and the miotic pupil actually remains smaller. So here's how the cocaine test usually works. Typically, you'll instill 2 drops of topical cocaine, either 4% or 10% in each eye, and then measure the degree of anisocoria after about 45 minutes. And usually a positive test will be considered if there's 1 millimeter or greater of anisocoria at that time. So you can see in this gentleman here, A is prior to any installation of the drug, and B is after. And you can see that in that right eye, he has a miotic pupil, and he is also a little ptotic in that eye. And in B, there's a little bit there's still a pretty significant amount of anisocoria. He's still pretty ptotic too. So this would be a positive cocaine test indicating that he is positive for Horner syndrome. And so the other test is an apriclonidine test, which mechanistically, it is a strong alpha-2 and a weak alpha-1 adrenergic agonist. It's more readily available alternative to cocaine, but it could be contraindicated in certain like young pediatric patients because it can cause CNS depression and respiratory depression. But in healthy eyes, it has very little effect on pupil size. In fact, the alpha-2 effect may cause a little bit of the oppositional to the alpha-1. It can cause a little bit of meiosis. But in Horner syndrome, the alpha-1 effect dominates because there is a certain denervation supersensitivity in the affected pupil. So this results in relative mydriasis by contracting the dilator muscle. So in this test, you instill 1 drop of apriclonidine, typically 0.5 or 1% in each eye, and then you measure the anisocoria in 60 minutes. A reversal of the anisocoria is confirmatory for Horner syndrome. So you can see in this top image, this is before installation of any of the drops. And then in the bottom image, that left pupil that was more myotic and that also had some ptosis, you'll see that the palpebral fissure has widened and that the pupil in the left has dilated, and actually the anisocoria has reversed, in fact. So that confirms Horner syndrome. So once it's confirmed, you can, if you want to be extra fancy, you can use hydroxyamphetamine that can help you localize the defect in Horner syndrome. The idea is that amphetamines enhance the release of norepinephrine from an intact postganglionic neuron. So the pupil should dilate if it's normal. If the affected pupil does not dilate, then typically that indicates that that third order neuron is not working properly. So if both pupils dilate well, then, and you already know they have Horner syndrome, then the lesion is typically either the first or the second order neuron. So in this case, you instill 1 drop of hydroxyamphetamine in both eyes, then you wait 45 minutes, and then you reevaluate. So in this woman, we know that she already has Horner syndrome. We've already identified that, and we want to see which, where's the lesion. So you can see that that right eye is the one that's affected, and we've given her the hydroxyamphetamine, and you can see that now it's dilated in B. And so that indicates that that third order neuron is actually intact, and so it must be more proximal. All right, so coming back to where we are on this flowchart, we've kind of worked our way through that left side. So we should be able to kind of make sense of all this, at least on the left side. You can see that, the cocaine test and the aproclonidine test, and how that will lead you to either Horner syndrome or physiologic anisocoria. So to go more onto the right side of things now, we'll talk about the AD pupil, which is essentially a denervation of the postganglionic parasympathetic supply to the sphincter pupillae and ciliary muscle. Typically affects young women. Actually 70% of the time it does, and then most often presents in one eye, about 80% of the time. And typically they'll show up with a large pupil, absent or sluggish direct and consensual light reflexes. You may see vermiform movements of the pupillary border. And the pupil will respond very slowly to near, and then following that, redilation is often very slow. In long-standing disease, the pupil may become very small, in which case the mnemonic little old 80 can be helpful to remind you that. And it can also be associated with diminished lower limb deep tendon reflexes. This would be Holmes-80 syndrome and other features of autonomic nerve dysfunction. So the test for AD is pilocarpine. And the mechanism behind this is that in AD pupil, you get a denervated iris sphincter that's highly sensitive to a very weak parasympathetic solution, such as dilute pilocarpine, 0.1%. So you instill the eye drop, and then you wait an hour, and the affected pupil will have constricted more than the normal pupil. And about 80% of patients will demonstrate this kind of supersensitivity response. So here's a young lady who has a tonic pupil in that right eye, and you can see that after instilling 0.1%, that pupil has constricted considerably, and that the other pupil on the left-hand side, or her left-hand side, is relatively unchanged. So that would be a positive test. Another possibility is acquired cranial nerve 3 palsy. A complete nerve palsy would look like ptotic. You'd have limitation of the extraocular movements. Typically a down and out gaze is kind of the classic one that we think of. And oftentimes they'll have a dilated and sluggish pupil. A partial palsy, they may present with variable duction limitation, a variable degree of ptosis, and possibly pupillary dysfunction. When the pupil is involved, because the parasympathetics are typically on the peripheral or the outside of the nerve, you must exclude an aneurysm. And then if the pupil is spared and all the other functions are completely paretic in nature, an aneurysm is unlikely, and microvascular ischemia should be higher on your differential. And I would just mention too that in acquired cranial nerve 3 palsy, that the function of the actual muscle itself is intact, and so it will respond to the pilocarpine, but it's not super sensitive like it would be an AD pupil. there's not the same denervation sensitivity. So another possibility is pharmacologic mydriasis. So in this one, you have unilateral exposure to a mydriatic agent. Anticholinergics and adrenergics are two of the big ones that you need to think about in this context. In anticholinergics, you lose reactivity to light and your stimulation and accommodation is impaired. So oftentimes they'll show up with the addition of not only the anisocoria, but also blurry vision as well. And then in adrenergics, the palpebral fissure is often widened and the conjunctiva may be blanched, but accommodation is typically not impaired. And in both of these cases, the pilocarpine typically does not really have any effect on the mydriasis. So some examples of anticholinergics include atropine, homatropine, tropicamide, cyclopentolate, Jimson weed. There's a number of different sort of plants that can do this, and they act on the muscarinic receptors in both the pupil and the ciliary muscles. And some sympathomimetics include adrenaline, clonidine, and phenylephrine, and they act on the alpha-1 receptors, causing mydriasis of the dilator muscle. And then finally, another possibility is blunt trauma. So this can cause meiosis or mydriasis, often associated with a poor response to light and near stimulation. Oftentimes you can tell based on history if this is something you need to think about. And also you should look on slit lamp exam, see if there's any evidence of an irregular pupil, if there's notching or transillumination defects around the area of the sphincter muscle. And typically this will not respond well to pilocarpine either. So it may mimic pharmacologic mydriasis, so keep that in mind. So we've pretty much talked about everything that's now on this flowchart, so we should be able to kind of reason our way through it. So going back to our patient, we'll kind of walk through it. So in her case, we found that both pupils did not react normally to light, as we could see on that first picture. And the anisocoria was, in fact, not greater in the dark. So we find ourselves going onto that right side. There was no history of any trauma. And on slit lamp exam, there was no visible damage to the iris. There was no iris palsy that we could appreciate that was sectoral. So we moved on to do a pilocarpine test. And she ended up, essentially, she wouldn't react to even the 1% pilocarpine. And so that was indicative of a pharmacologic anisocoria. So she didn't initially volunteer it at first, and it was not in her chart because I think it was prescribed by an outside dermatologist, but she, after we kind of pressed her on it and talked to her a little more, she recalled that she did start Qbrexza, which is something that was prescribed by her dermatologist for facial sweating. And she reports that she had actually used these wipes prior to changing her contact lens in the right eye the night before. And she hadn't washed her hands. So Qbrexza is a prescription cloth. It's a towelette used to treat typically excessive underarm sweating, but apparently this dermatologist was going to use it for facial sweating as well. And it's an anticholinergic that competitively blocks muscarinic receptors. All right, and then I saw an interesting study in the American Association of Pediatric Ophthalmology and Strabismus, just related to anisocoria. This was published in 2013, and the purpose was just to investigate pupil size and to look at the incidence of anisocoria in children at a single community-based practice. So essentially, it was a retrospective review. They took patients essentially from 17 years of age and under, who'd received a comprehensive exam, including photo screening with Plus Optics. Essentially what Plus Optics is that it's a photo screener that uses infrared and is capable of measuring both pupils simultaneously. So it makes for a great instrument to measure anisocoria. And what they found was that in these children, about 1,300 of them, that actually about 20% of them had significant anisocoria. So 80.9 had 0 to 0.4 millimeters of anisocoria, meaning that they didn't actually fulfill the definition. And then there was about 20% that did. And 16.8% of them had between 0.5 and 0.9 millimeters. 1.5% had between 1 and 1.4 millimeters, and a little less than 1% had greater than 1.5 millimeters. And the magnitude of anisocoria appeared to increase with age, and the size of the pupil and age were positively correlated, meaning that older children had larger pupils, not terribly surprising. But the average pupil sizes grew considerably fast between about the age of 1 to 10, and then it slowed down after that. And the average age around from 0 to 3 years was about 5.34 millimeters, and then up to about 16, 17, it was 6.27 millimeters. And of note, these were typically measured in dim light, just for your reference, and there was no significant relationship between pupil size and sex when they looked. And also, when it came to anisocoria, there was not a real preference for which side was affected, whether it was right or left. There was no association of whether the right side was more commonly enlarged or was more commonly constricted. So yeah, no significant relationship. Here are my sources, and hopefully that discussion can help you better approach a patient with anisocoria if you happen to see one in the clinic. And any questions?
Nice presentation. And I think the thing that, as you pointed out, this is incredibly common. I think a lot of times we don't record it as much, but if physiologic, up 20% of folks have it, it's pretty common. Okay, well, if no questions, we could go on to presentation 2.
I just wanted to say it was a good case, and it's something that you really should consider asking your patients as if they're on like a different medication. I saw one at Oshner when I was a first year, and I ordered CTA of the head and neck for possible Horner's in the middle of the night, and it turned out that the patient just got back from a cruise and had a scopolamine patch, and she would have avoided like a $2,000 to $3,000 charge of a CT, not to mention all the radiation and the risks that come with the dye, had I just asked her if she'd been using a new medication. So something to definitely keep in mind, but good presentation.
I also vaguely remember that some perfumes can do this. Not that anyone intentionally gets perfume in their eye, but I vaguely remember seeing someone like that years ago where it was a new perfume, and I think they rubbed their eyelid or something, and that was what we ascribed the cause to. So it's probably better to do these tests before you start ordering the CTs if there are no accompanying signs or any history. Okay, case number 2.
Sure, if she's here to present now.
Hello?
Hey, Maureen, you're here?
Yes, I'm here. Can you all hear me? Okay.
All right.
All right, great.
Yep.
So my presentation is titled Blind Spot. And these are my, CME slides. And the patient that I saw was in Dr. George Fifkes's clinic, and she presented with the chief complaint of having a central scotoma in her left eye for about 2 months. She was a 65-year-old female that initially presented in the general ophthalmology clinic, and she was referred to the retina clinic for further evaluation and management. Her review of systems was negative. She had a past ocular history of cataract surgery with intraocular lens placement in both eyes. She had a past medical history of diabetes, hypertension, thyroid disease, and heart disease. Family history was significant for hypertension and diabetes. And her medications are listed on the slide. And she had no known drug allergies. This is her external exam. Her best corrected visual acuity was 20/25 in the right eye, 20/50 in the left eye. She had no APD. Her pressures were 21 and 20, and extraocular movements and confrontational visual fields were full in both eyes. Her anterior segment exam was essentially unremarkable. She had 1 to 2 plus nuclear sclerosis in both eyes. And these are her fundus photos. How about a first year describes them for me, please? How about Dr. Morgan?
Okay, so these are color fundus photos of the right and left eye, respectively. The media is clear. The nerves look very abnormal. They're very like dark. I'm not sure if it's like bleeding around them. The vessels appear like tortuous coming out of the nerve. The macula is mostly flat and it looks like it has an okay foveal light reflex, kind of both eyes.
Sure, good job. So these are not the best fundus photos, to be honest with you, and it's just the nerves are actually normal. It's just the way the photograph is taken and just the resolution because of which the way it looks this way. But essentially, the findings are very subtle, but temporal to the foveal center in both eyes and primarily in the left eye. There's a slight graying, and it was more obvious on clinical exam than it is on the fundus photos. And essentially, the exam is listed here, and essentially what we saw in clinical exam is, excuse me, that there were some perifoveal telangiectatic vessels in both eyes, more obvious in the left eye than the right eye. And there was a mild halo temporal to the foveal center, mild halo temporal to the foveal center in the left eye. Other than that, the fundus exam in both eyes was unremarkable. How about John Williams? Do you want to talk about the pictures here? First of all, tell me what type of images are these, and then maybe if you want to comment on what you see.
Sure. Is this a fundus autofluorescence?
That is correct. Good job. Okay.
So those are FAF images of the right and left eye, respectively. Looks like parafoveally there's some hypofluorescent areas in both eyes, maybe the left greater than the right.
Good.
Otherwise,
good. So one thing that I'd like everyone to, and first years primarily, to kind of appreciate here is that primarily the left eye, and again the resolution is not that great, but the left eye, the normal hypoautofluorescence of the fovea is not present in the left eye, whereas you can appreciate it here in the right eye, but the normal hypoautofluorescence of the left eye is not present in the left eye over here. How about the OCT? I'm sorry I did not get the images where the segmentation lines were not present, but you can see what I'd like you to see over here. How about Dr. Matthew Williams this time?
So on the OCT, looks like, I'm guessing this is a right and a left, yeah. Preserved foveal contour, both of them. All the layers look intact except on the left. It looks kind of like a disruption in the RPE maybe, and with some like intraretinal fluid as well, little cystic space of intraretinal fluid.
Good. Good job. So yes, the layers in the right eye are all preserved. The foveal contour is nicely preserved here in the right eye, and there's this cystoid space, could possibly be fluid or just like a cystoid space in or a cavitation within the retina in the right eye. And similarly, a larger cavity present here could be fluid, just like you said, or just like a cavitation within the retina in the left eye. And there is a disruption of the ISOS line in the left eye over here. How about second year? Talk about the type of the pictures shown here and comment on what they see. Dr. Patel? Dr. Azar?
Is this ICG?
This is a fluorescein angiography.
Okay, fluorescein angiography.
Mm-hmm.
Oh, it's nervous arc. I mean, there looks like there's good flow. So it's fluorescein angiography of both eyes. So it looks like there's good flow through all the vessels. Maybe a slightly enlarged blinds or fovea, macula.
Yeah, possibly. So basically, what are you seeing here? This is just the right eye. We're only looking at the right eye over here, and what phase are you in on the left side, and what phase are you in on the right side?
So the left side is probably maybe AV phase, and the other one is recirculation. Good,
excellent. And so what you're noticing here, good job, is possibly just an area of hyperfluorescence temporal to the foveal center right here. Okay. And then how about Dr. Azar? Do you want to just finish this? This is the left eye.
Okay, so left eye, similar thing. You have AV phase on the left, and then recirculation on the right. And then you can also see that area of hyperfluorescence temporal to the fovea.
Excellent job. Good job. All right, very good. Third year resident, maybe over here. Any third year resident. What type of pictures are these?
This is OCT angiography.
Good.
Right and left eye respectively.
So I'm going to tell you that we're looking at the deep retinal capillary plexus over here.
Deep capillary plexus. So I haven't examined a lot of OCT.
Yeah.
Comparing the two sizes of the foveolar vascular zone, I mean, maybe the right's slightly larger than the left. I don't see any areas of sort of like an appearance of like a CNV or anything like that.
Good.
So overall, I would say fairly normal, but I'm not sure.
Okay. All right. Good. So essentially, I mean, you don't have a comparison of a normal eye here, but overall, the density of the vasculature is reduced overall in both eyes, and what you see is kind of squiggly lines, squiggly vessels. I'm sorry, around the foveal center or the foveal avascular zone. This is the foveal avascular zone, as we all know. And around these, around the foveal avascular zone, these vessels, they should not be squiggly like this. So these are all telangiectatic vessels, what you see around the fovea. Similarly over here. Okay. So we have a 65-year-old female that presented with a central scotoma in her left eye for 2 months. An exam and ancillary testing are significant for perifoveal telangiectatic vessels, subtle intraretinal cavitations or cystoid cavities on OCT, and parafoveal temporal leakage on dye-based angiography bilaterally. Any thoughts? Anyone?
For juxtafoveal telangiectasia.
Good. Excellent. Any other differentials?
Coates, but she's older for that, but just because of telangiectasias.
Sure, yeah. can think of other things that can cause leakage, parafoveal leakage, and CME, for example. So she's pseudophakic, so you can think of what else? Pseudophakic CME due to other causes. Anything else?
Yeah, Irvin gas,
Mm-hmm.
diabetes, CRVO.
Exactly. Good. Good.
Patient-induced.
Good. Yes. Excellent. So I think you all pretty much got everything. One other thing that, when you talk about idiopathic juxtafoveal telangiectasias, it's of 3 types, and we'll go over that. But essentially, type 2 is the most common. Diabetic macular edema, cystoid macular edema, pseudophakic cystoid macular edema, and cystoid macular edema due to other causes. When you see intraretinal cavitation, or it can actually look like a lamellar macular hole as well. Coats disease, and so you mentioned that. And then idiopathic juxtafoveal telangiectasia can also present with crystalline deposits, and that can look like crystalline retinopathy as well. So those are some differentials that you can think about. So based on the presentation and the exam findings and the ancillary testing, our top diagnosis was idiopathic juxtafoveal telangiectasia type 2. Our plan was to observe, and we have observed the patient for about 4 months, and she recently followed up, and she's stable. Her visual acuity is still 20/50 in her left eye, 20/25 in her right eye, and currently we'll continue to observe her. And I'll now talk about this condition. It's of 3 types, like we talked about. The type 1 and type 3 are the less common ones, so I'll just quickly talk about it, these 2 types in 1 slide each, and then most of my presentation is going to be about type 2. So type 1 is also known as the aneurysmal type. It's predominantly common in males. The mean age of presentation is 40 years. It's unilateral, prominent. The signs and symptoms are basically that it can present as more commonly like Coats disease, and the treatment is laser photocoagulation, and that may reduce the exudation, and it can stabilize vision. The visual prognosis is variable, and majority progress to 20/70 or worse if untreated. Type 3 is also known as the occlusive type. It's very rare, and it can present as bilateral perifoveal capillary obliteration, capillary telangiectasia, minimal exudation, and associated with systemic symptoms, systemic manifestations, such as cerebral disease. Treatment and prognosis is unknown due to its rarity of the condition. Type 2 is the most common form. So you're going to see some red highlighted stuff, and that's primarily the important stuff for your OCAPs and boards. So just concentrate on the red highlighted stuff from here on. The type 2 is the most common form. The gender predilection is equal for this type. It can occur in any age. Mean age of diagnosis is 55 years old. There's some genetic component to this type as well, and smoking may worsen the condition. It's a bilateral disease, but it can be asymmetric and may appear as a unilateral process early in the disease process. Patients often present with complaints of blurred vision, metamorphopsias, or central paracentral scotomas, just like our patient. She presented with a central scotoma in her left eye, and her disease was also kind of asymmetric, her left eye being the worst eye at presentation. Early changes include parafoveal graying of the retina, superficial crystalline deposits, subfoveal cystoid cavities, parafoveal telangiectasias, and right angle vessels. Right angle vessels are basically where your retinal veins dive deep into the retinal layers at right angles. And you can appreciate that newer studies on using OCT angiography have shown, very nicely shown this particular finding actually in some papers. Visual acuity decreases slowly and is often associated with hyperplasia of the retinal pigment epithelium. In approximately 1/3 of the patients, deep retinal neovascularization with retinal feeders and subretinal neovascularization may occur as a complication, which is then called the proliferative form. This picture from one of the references that I looked up, and our patient did not quite have the crystalline deposit, so I thought I'd share these fundus images with you, and you can nicely see these crystalline deposits, especially in the left eye. Fundus findings, especially even in our patients, can be quite, in our patient, were quite subtle. And so most of the time, fundus findings can be quite subtle, and especially early in the disease process. And fluorescein angiography highlights the parafoveal telangiectasious vessels that demonstrate leakage and are often more prominent temporal to the foveal center. OCT demonstrates your subfoveal cystoid spaces that are also called intraretinal cavitations, usually without cystoid macular edema. And in advanced stages, so just like in our patient, there can be photoreceptor disruption, and outer retinal atrophy can also be seen. Fundus autofluorescence characteristically shows loss of the physiological hypoautofluorescence in the fovea, just like in the left eye of our patient. This is a study that looked at the retinal microvascular changes in the using OCT angiography and MACTEL type 2, and basically the things that have been shown in patients with MACTEL type 2 using OCT angiography is enlarged foveal avascular zone that correlates with worsening visual acuity, decreased vascular density in the parafoveal area of the superficial retinal capillary plexus and of the entire deep retinal capillary plexus. And overall, what has been shown is that the deep retinal capillary plexus tends to be more involved, and the vascular density tends to be, the loss of the vascular density tends to be more exaggerated in the deep retinal capillary plexus compared to the superficial retinal capillary plexus. What's been suggested is that the pathogenesis is what's been shown is that it's basically a neurodegenerative process rather than a vascular process, and abnormalities in the parafoveal Mueller cells has been depicted as the main pathogenic process involved in this condition. And the cystoid spaces that are seen on OCT actually represent loss from retinal degeneration rather than cystoid macular edema. And that's specifically due to loss of Mueller cells. And the superficial crystals that are actually seen on the retina are due to, that are thought to actually represent foot plates of degenerated Mueller cells. And that explains why treatment with anti-VEGFs is not recommended unless there is subretinal neovascularization. So essentially what's recommended really is that you observe these patients unless you note any signs of neovascularization. And that's what this slide basically talks about, is that for non-proliferative disease, you don't treat. There is no known treatment. Anti-VEGFs, oral carbonic anhydrase inhibitors, laser treatment, PDT, steroids have all been tried, but no clear functional benefit has been seen. So you don't really treat with anti-VEGFs because actually VEGF is neuroprotective for retina, unless you see proliferative disease, in which case you would treat with anti-VEGF therapy. This is a phase 2 clinical trial looking at injecting ciliary neurotrophic factor in the vitreous of patients, and it has been seen that if you a surgical implant that releases CNTF into the vitreous cavity could potentially have a benefit of slowing the progression of retinal degeneration in eyes with MACTEL type 2. And the way they looked at it was after 24 months, they measured the ellipsoid zone disruption, and they found that there was a decrease in the ellipsoid zone disruption and measured on OCT in patients that were treated with a surgical implant that released CNTF, which also tells you that this is basically a neurodegenerative condition rather than a vascular condition, at least in the non-proliferative stage. Prognosis is variable. 2/3 of the eyes will progress to 20/70 or worse vision associated with the retinal pigment epithelium hyperplasia or subretinal neovascularization. And when they develop subretinal neovascularization, then you treat with anti-VEGF therapy. So again, the take-home points, I basically went over pretty much all of this in the previous slides, but MACTEL type 2 is the most common type of MACTEL that presents with bilateral parafoveal graying of the retina, superficial crystalline deposits, parafoveal telangiectasias, and right angle vessels. These are all buzzwords for OCAPs and boards. OCT demonstrates subfoveal cystoid spaces, intraretinal cavitations. Fundus autofluorescence shows characteristic loss of physiologic hypoautofluorescence in the fovea. And fluorescein angiography depicts leakage of the parafoveal telangiectatic vessels. No treatment for non-proliferative disease at present. Just reassure your patient, and for proliferative disease that involves subretinal neovascularization, you treat with anti-VEGF therapy. These are my references, and I'd like to thank Dr. Fifkus for sharing this case with me, and I'm happy to take any questions, comments. Thank you.
Good presentation, Maureen. Maureen, do you know what kind of machine does Dr. Fifkus use for his IVFAs?
He uses, so he does, alternatively, he'll use either Optos for wide field, and he'll also use the Heidelberg.
Got it. Yeah, it's just, you know, I kind of understand why Marlene got a little confused with the IVFA, thinking it was an ICG, because the optic nerves look dark on that one, which is kind of rare for an IVFA. That's why I was asking. It may be just a Heidelberg thing. Yeah. The pictures that you show where the nerves look kind of dark, that's also in a Heidelberg, and it's not true color. So I'm wondering if that has, you know, if that's why it looks kind of weird. So just wanted to make a comment on that. And then I guess the second thing is, as you mentioned, you know, these patients with MACTELs, they do get a lot of outer retinal atrophy to the point where they can get a macular hole. Yes. And unfortunately for these patients, actually surgery really doesn't work. You can go in and do an ILM peel with gas bubble, and you know, I would say almost 100% of the cases it will not close, because it's not that the regular macular hole where you have like tangential forces that are producing the macular hole. It's just loss of tissue. So just keeping that in mind is whenever you see these patients and they have the diagnosis of MACTEL and eventually they develop a macular hole, it's just really poor prognosis, and usually surgery is not the way to go.
Sure, thanks.
But that's it. Everything else was a great review.
Thanks.
All right. If there are no more comments or questions, I guess this concludes our ground round session, and then residents can start with questions.